Hello and welcome to the Chris Wolf Podcast on iCode Media. Today I had a great conversation with Dr. Blake Cooper, and we discussed patients who are living with diabetic retinopathy, specifically diabetic macular edema, clinically significant macular edema. We talked about Protocol V and Protocol W, which I think is really helpful for us as clinicians to know when we want to make the right referral. And I think part of that is just having a great retinal surgeon that you have really good communication with. So please enjoy our conversation. It was a lot of fun for me to discuss this with Dr. Cooper. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. Listen, if you're trying to enhance a protocol in your practice, and you're trying to answer whether or not you can integrate this protocol in a way that allows you to take care of patients who have both medical and managed vision care needs, we've got the thing for you. It's called Total Patient Care, iCodeEducation.com. We also have a mastermind group that is quickly forming and quickly filling up for this summer that's going to start and launch on June 1st. So don't wait, get access. We'll have a coupon code now in the show notes that will allow you to access that at a discount and jump on board with the Summer Mastermind Total Patient Care group. It will help you answer the questions that you're struggling with within your practice to integrate new protocols and new disease state management. Check it out, iCodeEducation.com. That's EYECODE education.com. One of the challenging things with patients is that when they invest in a really high quality pair of glasses and customized lenses, occasionally it can be difficult to keep those lenses clean, scratch-free, and smudge-free. Now, we have the ability with Crizal Sapphire HR lenses to offer our patients a best-in-class anti-reflective coating that is also resistant to scratches, smudges, and deposits. This means that patients spend more time enjoying clear and comfortable vision and less time caring for their lenses. So remember that you can provide patients with the best in quality, best in class, transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal. So thanks for jumping on. You know, you and I had a great conversation, although brief, a great conversation in Dallas about a month ago now. And one of the reasons I want to have you on as a retinal surgeon is because my philosophy, and maybe you picked up on this, maybe you didn't, but my philosophy in terms of patient care is to use the right people at the right time in all of those patient interactions. And one of the things that I really have come across in reading the literature, but haven't really had an in-depth conversation with anybody on the podcast is this, and I'm probably going to even butcher it because I don't know if it's Protocol V or Protocol Roman numeral 5. But I'd like to talk about that a little bit because it's really interesting to me because we always think that DME, diabetic macular edema, needs treatment. And this tells us maybe we just monitor them. So can you talk about a little bit about Protocol 5 and how you use it in your practice? Or is it Protocol V?
Well, again, I think it's the concept is there. It's Protocol V, and it gets back to the fact that they're starting to run out of letters in the alphabet, and they're now starting to duplicate some of those letters. So, you'll see Protocol AA, or you'll see, several protocols within the DRCR net. And so what you're really talking about are randomized clinical trials looking at sort of the way we treat somebody who lives with diabetes, right? And, for Protocol V, you can think of V like very good vision, right? So somebody comes in, they have 20/20 vision, they have diabetic retinopathy of some level, right? They might have, evidence of macular edema. And the question is, what do you do with that patient, right? And the question is, can you watch them and observe them? It depends where that edema might be, and as we sort of changed sort of the way we tend to think of it as either being centrally involved or not centrally involved. And what that protocol showed us was that not everybody needs to be treated. So after a few years of observation, visual acuity was the same as compared to those who were treated, right? And now, anatomically, the retina might have looked better, right? You might have had less severe disease in those who are being treated with an anti-VEGF agent. Their macular edema might have improved, but as far as, the DRCR net studies, what they're really trying to answer are very specific questions is to, like you said, what do we do with that patient, right? And what's important to understand whenever you look at a clinical trial is who was being treated, right? And under what circumstances, and then the duration of the trial. So those who live with diabetes do so for decades, right? And a short period of time, although 2 years seems long, may not be long enough for us to really know the final result or what's best. And so then you have to factor in treatment burden, you have to factor in cost, right? And the art of medicine is trying to figure out when we really intervene with and start treatment. And a lot of it is, very, very specific for that moment with the patient in your chair, right? So I think the question is, when does that patient show up in our chair, right? And that's probably a good place to sort of discuss is when are you going to make a referral? When do we sort of say, well, no, we don't need to see that patient, and under what circumstances?
Well, I think that's what's really helpful with, so just so the audience knows, Dr. Cooper and I are not in the same town. We don't practice in the same town. So we don't share patients. Although just my interactions with him so far would suggest that I would be completely open to sharing patients if we were a lot closer. Sure. The thing that I think about is, we kind of remember back when we're taking care of patients who have diabetes and those patients have diabetic retinopathy, we sort of rely on, what we would call clinically significant macular edema. And actually what's interesting about that definition to me is it was defined really previous to when we had OCT technology. And so it was almost ophthalmoscopic thickening, which I think is kind of lost because then we can look and detect super minimal thickening on OCT where we would never notice it ophthalmoscopically. So as the optometrist, as the referring optometrist, so I have a patient, let's say that, again, we're having a hypothetical conversation, but let's say their A1C is 7.5 and they are doing the things they can try. Let's say their internal medicine physician is trying to stay on top of them. They're working on their diet and exercise, maybe some new medications as well involved in that. But we see some small amount of retinal thickening on OCT, but not ophthalmoscopically, and the patient is 20/20. When do you want to see that patient?
Yeah, so I think a lot of it's going to depend on your experience with that patient, right? So is this somebody that is fresh in the door, the first time you've seen them, and you see that they're doing everything that they need to be doing, and they have good vision, and they might have some central involved macular edema. I still feel like that patient probably could be observed. Now, not at an annual visit at that point, but you might want to bring that patient back either in 4 to 6 months and sort of repeat an OCT and reevaluate and sort of see how they're doing. Now, if it's somebody that you have, seen and you can see that the retinopathy is progressing, right? And you've had the conversation that if they are worsening, that you're going to sort of send them on, right? Then you might want to get them in for an initial evaluation, and then maybe that's a patient that we sort of share, and you see them once a year, and I see them once a year. But if there's a change, then we get them back either from either direction. But if we get back to that hypothetical patient, right, I guess you mentioned newer medications. So what I would want to know is, okay, did they just start GLP-1 receptor agonists? So we have these different classes of new medications, right? And there's the drug that we all know for weight loss that people are taking, semaglutide or Ozempic, and that medication when it was being studied. So if we back up a little bit, all medications for those who live with diabetes have to go through cardiovascular outcome trials. And it's not only to show that they're beneficial, for their glycemic management, but it's to make sure that they're also safe. Because years ago with the Accord study, where they tried to really have very, very tight control for those who live with type 2 diabetes, they saw an increased rate of mortality. And so after that, the FDA really mandated these cardiovascular outcome trials, and that put a big treatment burden for getting drugs approved.
There?
Yeah.
Blake, can you pause there for just a second? So I am familiar with that, but is your take from that the reason that they had a higher risk for mortality, was it because the medication they were using did cause poor cardiovascular outcomes, or because there was so little wiggle room that they were almost over treating? I mean, what was your take from that?
Yeah, so I think the take on that was medications are safe when used appropriately. However, people were targeting an A1C within a normal range, right? And so what that meant was a lot of people who lived with diabetes for a long time, who had cardiovascular disease, were becoming hypoglycemic, right? Blood sugars were dropping below 70, and sometimes, below 55. And then that cardiovascular stress is to drive down the average A1C or average blood sugar over a 3-month period of time, was what was causing, mortality, right? And so what we've realized is that we would much rather have somebody in a range, let's say 70 to 180, 70% of the time, rather than a hemoglobin A1C of 7, right? So, and then within that, we want to make sure that the glycemic variability really is not fluctuating. So we don't have this, huge excursions. But the point is, lows were what were driving that mortality rate. But there was questions. There were certain classes of medications, the glitazones, essentially like pioglitazone, that did show an increased rate of mortality, and so the question at the time, this is going back probably 2006, we didn't really know what was causing. So the FDA mandated these cardiovascular outcome trials. Well, so for the GLP-1 receptor agonist, semaglutide or Ozempic, that trial was a SUSTAIN 6 trial. And in that trial, there were a wider range of people who had diabetes. So you had a much wider range of hemoglobin A1Cs, A1Cs in the 10s, right? And the effectiveness of that medication is that it probably would see about a 2% reduction in overall A1C when you started that medication at therapeutic levels. And that process, we know from other medications, let's say if somebody starts insulin therapy, the retinopathy is going to progress, right? And so what they saw was a higher rate of retinopathy. Now, those patients weren't seen by eye care professionals. It was just, they had an eye event, whatever that might have been. Could have been a PVD, could have been something, but regardless, they had more essentially defined retinopathy, whatever that, take that what it is, right? They weren't seeing an optometrist, they weren't seeing an ophthalmologist or retina specialist, but they had higher rates. And we've sort of seen that over time, that, if you get back to the days of the DCCT and EDIC trials, where we saw sort of this early worsening of retinopathy, right, with better glycemic control, but long-term patients do better, right? So, my point is that if that patient, the hypothetical patient we're talking about, had just started semaglutide, right, and then you were seeing some retinopathy, that could be a patient that you could continue to monitor and watch and tell them, yes, we know your retinopathy is going to probably get a little bit worse, but your glycemic control is going to improve, and we're going to watch this, and we're going to have you back and follow you closely, right? And if they have good vision, that's a very reasonable approach for that hypothetical patient. So you really have to sort of get into what their glycemic management is, right? And part of, how I approach my patients who live with diabetes is, I'm looking at, do they have a continuing glucose monitor? What is their time in range? What is their, we call it the coefficient of variance of glucose, but that fluctuation of their, glycemic, management, we hate to say control, but the concept is there that you want to make sure that they're doing everything they can to maximize the risk factors that they have, right? And that goes a long way to how they're going to do 4 or 5 years from now, right? I mean, they certainly care about what's happening that moment, but it's really hard to sort of pinpoint the direction somebody's going, right? And that's where I sort of rely on you, is to say, okay, I've been watching this patient for years, they're declining, and that's the time for referral, right?
So you brought up a couple points there that I think are helpful to dig into. The first one is, to me, it seems completely obvious that you'd want to have a continuous glucose monitor. I mean, regardless of how long you've had diabetes or or how long you've had to live with it. But there seems to be some pushback in payers. And is that because the evidence just isn't quite there until you hit a certain level of challenges with blood sugar control? I mean, why are we seeing that not every patient with diabetes just has an automatic link to their phone that they can just scan and get information?
Yeah, so I think it's a personal decision, right? I mean, we have to sort of take it back to the patient level, right? And it makes sense to us as sort of eye care professionals that yes, everybody should have one, right? It's sort of an easy concept. But when you ask somebody that lives with diabetes to have to think about it more than just a few times a day, right? I mean, they're getting information every 5 minutes, which is tremendous to know which direction they're going to go. But to have that burden and living with it 24/7 and thinking about it, it's impactful. Sort of from a personal standpoint, my oldest daughter has type 1 diabetes, right? And,
I was hoping you'd bring that up.
So she was diagnosed at 12, and she's 23 now, and it's been sort of a very interesting sort of perspective. I mean, so I've been practicing for 20 years. The first 10 years, I cared for people with diabetes, and the last 10 years, I've done as well. But my perspective, I think, has changed a little bit, right? We have these targets and these goals, and we tell people it's important, but it's the mental challenge of living with a disease all the time that can be challenging, right? And so she's been very fortunate, right? She's a smart kid. She's a first year med student, and she's been able to have every resource possible, right? So when she was diagnosed, at the time, insurance wouldn't cover a CGM or an insulin pump for the first 3 or 4 months of her diagnosis, and that you had to prove.
What was the rationale?
So I think it was so that they would get used to being able to manage diabetes with injections, right? And understand what a basal insulin was, what a short, long-term acting insulins were, how they worked, and understand, that portion of it, so that if their pump failed or if something else failed, it would be important. From a CGM standpoint, they wanted to prove that they were having episodes of hypoglycemia that warranted that risk, right, of needing extra help or extra understanding. And then oftentimes for those who live with type 1 diabetes, there's probably a few months, maybe a year or two, where they're in this sort of honeymoon period where they still have some functioning beta cells, and those beta cells are still producing some insulin, so they may not have the large fluctuations. But fortunately, we can afford it, and so we just automatically put her on a insulin pump and a CGM monitor, and then she got actively involved with the JDRF. So she testified in Congress in 2015. Advocating for Medicare coverage of the CGM devices, right? So this was going back only, 2015. And then a few years later, Medicare then picked up on CGM. So CGMs have evolved quite a bit as far as their accuracy, their comfort. Again, there were some sensors that were very uncomfortable to wear. Now they've gotten smaller. And I think, we're catching up to that, right? Patients who used to use them are coming back to them. You have, elite athletes that are trying them to sort of try to see what happens with their, nourishment, with their blood sugars, which I sort of find humorous. But so I think the technology is there. The cost is probably coming down. It's just, insurances are variable, right? And not everybody might have insurance, but they don't have the same level of coverage, right?
Yeah.
Which can be frustrating.
Yeah, I think that's kind of another rabbit hole we could dig into a little bit. Is just the the ability to, and I think that there have been some studies on it, but it's been only short-term gains, but the idea that even patients who don't have to live with diabetes, or like you and I, could gain some insight in terms of just understanding what our blood sugar does throughout the day, so that we are trying to avoid some of those spikes, which is a peripheral to our conversation. But it's kind of interesting. I think I read something that they had like 2 years of data, and it basically showed that initially people really paid a lot of attention to it, and they would prevent a lot of spikes. But then over time, it was relatively ineffective at patients who don't have diabetes. Maybe I'm misremembering, but that's what I recall from it. So I wonder if that same issue occurs. Like, did it occur with your daughter when she had her first CGM, where it was helpful a lot at first, and then just it didn't make much difference, or it's because you have to manage that condition. You can't just be like, yeah, I'm going to have a tub of ice cream tonight. You have to know that that's going to be a problem.
Yeah. I mean, there's definitely a cause and effect that you can see, right? So you'll realize that, your glycemic challenge, whatever it be, a tub of ice cream or a plate of pasta or pizza or whatever, is going to have an issue and an effect, right? And then you manage it by, you walk after you eat, or you go for a run, or you bolus before to cover the carbs you're taking. And so you sort of learn a lot of that. But she's been fortunate that she's been sort of in this sort of closed loop system. It's really sort of a do-it-yourself version. So she has a insulin pump that is a patch pump. So there's no tubing with it. It's I don't know if we want to say drug companies or not, but that pump connects to her CGM device, and then there's an algorithm that runs on her phone that will bolus her if she's going high and suspend insulin when she's going low, and that process is sort of, she's been in a do-it-yourself version of that for probably about 5 years now, which really takes a lot of the mental burden away from it. You still have to, sort of watch what you're doing, but it's sort of nice to wake up with a full night's rest, right? You weren't up at night chasing a low, and you weren't bolusing for a high. You feel better because you got, a decent night's sleep, and you start close to in range, right? So she's starting at 100, and from there, she's had 8 good hours, and then she manages it as well as she can, right?
Yeah. So there's a couple things that you also brought up that I think would be helpful to get your perspective on. The first is, I always tell my patients who are living with diabetes that I can't know how challenging it is because I don't have the condition. But I see all these patients that do struggle. What do you feel like is a good builder to show that you have empathy for your patients who are struggling with these things? Like, say it's not that patient, the hypothetical patient that I presented first, it's already doing everything they should do, but it's a patient that's sort of grumpy because they got to see you. They're grumpy because their vision is down. They're grumpy because now this is another copay. They don't really want to do a whole lot anyway. I mean, do these patients come into your practice often? And if so, how are you building rapport with them so that they want to execute a strategy that helps them long term? What are your thoughts about that?
Yeah, so I think there's a lot to the language we use, right? And so, people feel like they're being graded constantly, right? And they feel like they're constantly failing when it comes to managing diabetes, right? Because we're sitting here with these target ranges that will help reduce risk for long-term complications. But patients, as who live with diabetic retinopathy could be pretty asymptomatic and have severe disease, right? And so they see well, so they have a hard time understanding that why are they here? Why do they have to go see the podiatrist? Why do they have to have an endocrinologist or a nephrologist or a whatever ist, right? And it's a lot of treatment burden. By the time someone starts treatment for macular edema, they'll probably have 25 physician visits when you break it down over the course of a year, right? So that's a month of seeing a patient, seeing a physician of some sort, which is overwhelming, right? So I think starting with the understanding that you're there to help them manage a disease that's not manageable, right? And to show them why it's important, right? So we have these tools in our offices, fundus cameras, OCT images. We have lots of things where we can sort of say, this is why you're here, right? We're watching this, or this is getting worse, and this is something that we have hope for, we have treatment for, and understanding that this could lead to visual loss, right, is fine. But starting with, you're going to go blind if you don't do this, is different than, I understand that, this is catching up with us, and now we have to, try to sort of figure out a way to sort of slow it down or reverse the course, right? Or try to help improve things. I think one of the hardest things about, some of those other, alphabet protocols, right? Whichever ones you want to sort of touch on, protocol W would be one of them, but is what is it significant if we can reverse the stages of retinopathy, right? And that's the part that honestly we just don't really have an answer for, right? We have, anti-VEGF agents that will reduce the level of how we grade retinopathy. And we're still working around whether or not that is important, and it certainly is important, but trying to sort of show that there's ways to sort of reverse something that's getting worse is very, very powerful, right? And I think it's very motivating. The hardest challenge you probably have, I would imagine, is you see somebody who you feel like needs to be referred, and you tell them, and then they don't seek out that next step, right? And getting them, to make that commitment is important, and part of it is, you have this ability to say, I know this person and they can help you, as opposed to, oh, you're getting worse and sorry.
Well, I never think that. I mean, the patients that in our practice. So there's 3 of us docs and all optometrists in my practice, and it seems to me that over my 15 years of practice, the ones that are challenging when they need to be referred are not the ones that are continually showing up in our office. The ones that are following, where we might be seeing them every 6 months, 12 months, 4 months, depending on what level of retinopathy they have. Those are the hard ones. It's the ones that come in every 3 or 4 years, and now they've fallen off a cliff, and they're finally coming in because their vision isn't very good. Or maybe they're sort of peripherally aware of it, but they haven't been paying attention. And so they're kind of like, yeah, my vision's not that great. And then you're like, okay, well, we can do something about this. I'll show them all their images. I'll say, look, and I'm almost positive. I'm saying, look, in the past, when I was trained, think about that. You were the same way. When I was trained, anti-VEGF medications were like just coming out. At best, our treatment protocols were to burn the retina and prevent it from developing new blood vessels just by killing it, right? And so the awesome part is we can prevent that, right? We don't have to do that anymore. But anyway, so it's just, but then they will resist, so it's the patients that come in, every few years. And then those are the ones that I have the hardest time referring. It is not the patients that, we've been watching closely, and now all of a sudden they have a little vision loss. They have enough DME to send for treatment, and they're like, yeah, done. They get it. So I don't know if that's been your experience as well, but that's from primary care. That's my experience.
Yeah. And do you feel like the reason for that challenge is patients understand that anti-VEGF therapy is an injection, and they fear the idea of having an intravitreal injection? Or do you feel like it's overwhelming and it's too much for them, and if you can't help them with a refractive error issue, they're gonna not move forward?
As you know, patients with vitreous floaters are often frustrated by their symptoms. The challenge as clinicians is to offer solutions for our patients for vitreous floaters that are effective. But more often than not, the options of YAG vitreolysis and vitrectomy are not practical because the benefits don't outweigh the risks. That's where Vitreous Health from MacuHealth comes into play. Previously on the podcast, I've discussed the FLIES study with Dr. John Nolan, and the bottom line is that I can be confident prescribing this for my patients with floaters because I can tell them a large randomized placebo-controlled trial found that after 6 months of supplementation with Vitreous Health, floaters were reduced in size by approximately 30%, and 70% of patients had an improvement in their symptoms. Vitreous Health has been great for my patients, and we really feel like we have a viable option to treat patients with vitreous floaters now that we didn't have before. If you're not utilizing Vitreous Health for your patients, reach out to your MacuHealth representative now. Young and emerging presbyopes can be tricky. These patients want and need additional help at near, but they can be resistant to solutions that create even mild distance blur. The MyDay multifocal lens has been great for our presbyopic patients. It allows those patients to transition into a multifocal more easily. We've had this lens now for long enough that we've been able to see how simple transitions can be from an adaptation standpoint from lower ad designs to higher ad designs. The MyDay multifocal material is CooperVision's softest one-day hydrogel lens and features aquaform technology combining the unique balance of high oxygen permeability with natural wettability in one material. The result is a highly breathable lens that keeps our patients' eyes looking clear, white, and healthy. So if you haven't started utilizing MyDay multifocal in your practice, I'd encourage you to reach out to your CooperVision representative to get started. Yeah, I think it's probably less of the fear of an intravitreal injection for most patients. I think it's more about, I think it's more about, I just want a simple fix, and they don't see it as a simple fix. But I could be wrong. I mean, I think most of the surgeons that, the patients are a little apprehensive about it, but, the surgeons that I use for those are, I mean, they've got great bedside manners. They do an amazing job trying to make the patient as comfortable as possible, both like emotionally and physically. But I don't know. What do you think? Do you think that it's more about the fear of the intravitreal injection?
I hope not. I mean, I hope that, by the time that they've been through an injection that, usually the response is, that was it. I worried about it for nothing, or, it wasn't as bad as I thought. I had one lady tell me she'd rather have childbirth than go through that again. Oof. But I think that was just the mental aspect around it, like the fear of having an injection, right? I mean, I think that you're right that, we've shifted away from, we're going to use either focal or panretinal photocoagulation to prevent visual loss, to we now have the ability to gain 2 lines of vision, right? So when we look at it, with laser treatment, the outcomes were, okay, we're going to prevent moderate or severe visual loss, right? As opposed to, we can actually now gain vision and hopefully maintain reading and driving level of vision, right? Because I tell my patients, you're not going to be 20 years old again and see like you did when you were 20, right? But if we can keep you 20 functional, reading, driving, maintaining employment, right? That's a huge benefit, right? And I think that, treatment burden aside, patients who can move forward in their lives and be productive are going to be more engaged with the idea. I think that, as you have to tell somebody that they no longer can drive, right, because of their level of vision, that's a motivating factor. I mean, the hard part about, again, living with diabetes is you have a lot to deal with, right? And by the time they have severe retinopathy, usually their glycemic management is the best it's ever been. That's the most frustrating portion of this disease, is that, we're not replacing vessels that are damaged, right? We're just trying to sort of prevent further loss of the, structures that they were born with. And until we get to that point where we can regenerate, nervous tissue and, replace vessels or prevent, them from really getting to that level, we're going to still be dealing with patients that lose vision. And that's very, very, very frustrating.
You mentioned Protocol W. Let's talk about that for a second. Tell me about what that is.
So it's sort of in the mid-range of where, so they're waiting on 4-year data. But the concept and again, it sort of becomes alphabet soup after a while, right? For all these protocols, but the concept was if there's a anti-VEGF agent that had a specific clinical trial that was the Panorama trial, and Protocol W is sort of that version of that trial. But what it looks at is the level of retinopathy, right? And do you impact visual acuity by reducing level of retinopathy, right? And so we know that patients will progress over time, right? They reach a tipping point. If we look at, the diabetes severity scale, when they hit that level, 47, 53, the sort of moderate, severe non-proliferative retinopathy, the risk of progressing to proliferative retinopathy within a year is higher. And those are the patients you want to prevent from developing macular edema or developing neovascularization. And if you can stop or halt that, or reverse the stages, right? If we can see a two-step improvement, that's meaningful. And what we've been challenged with is
let me pause you. You said two-step improvement. So what do you mean by that?
So that's a great question. So when we rate retinopathy, right, mild, moderate, severe, you rate it at
you're going from severe to
right?
mild.
So you go from, let's say, level 47, one step in the reverse direction would be level 43 and then down to 35, right? So you take them from moderately severe down to more towards the moderate or mild level of retinopathy, right? So anatomically, they have less venous beating, they have less intraretinal hemorrhages, fewer microaneurysms. You look at the retina and it doesn't look as angry, right? So we're able to sort of reverse that appearance. And it's good for what we see, right? But what's it do for their vision, right? So Protocol W said, doesn't do much, right? And patients can have this intravitreal injection and the treatment burden, but in the end, after a couple of years, vision was unchanged, right? And that's not surprising, right? If we really think about it, it takes years or decades to develop retinopathy. So I think we're realizing that a lot of these studies need longer follow-up, right? And the challenges with that is that we're doing better managing diabetes, right? Patients are living longer. They're not dying of heart failure because a lot of these newer classes of medications are helping with that portion of it. They're doing better with their, blood pressure, their cholesterol levels, and their glycemic management is improving. So there's so many different factors that get into it that, I usually have to sort of, when I start treatment, really have to sort of take a step back and say, okay, why am I treating this patient, and how is it going to positively affect their disease process, right? And oftentimes it may be that this is a patient, even with, when you send them in and they look like they're worsening and their level of retinopathy is severe, that we're saying, we're going to watch for a while, right? Or you see somebody and you're like, well, I'm not sure why they're starting treatment. And I think that it's a challenge, even within, my practice. So there's 11 of us in practice, and we all do things differently, right? We treat patients the way we see is important. And, I like one of the newer classes of intravitreal injections that is a biphasic antibody because it reduces treatment burden, right? So if I can treat somebody 3 times a year, right, that's better than monthly, right?
Yeah.
And so I think that as, we look forward over the next decade or two, we're going to have a lot more treatment options available to help our patients, right? But it's the challenge of saying, okay, when is it important, right? When's it important for the referral? When's it important to start treatment? And there's no right answer, right? I think that, it's sort of what that conversation is like with the patient in your chair. And when you sort of talk through it, some people say, I want to do everything possible to, right. Or some people say, I'm comfortable watching, and
the problem with the everything possible too is that, as you alluded to, it's like, well, we assume that everything possible is going to be all upside, right? Like when you talk about the treatment burden, even if we have the ability to do an injection every 3 months, and let's say we reduce, as you're talking about, 2 steps. So let's say we go from moderately severe to mild retinopathy or low moderate retinopathy. Well, in the patient's mind, they're thinking, well, I'm doing everything I can do, right? So as you alluded to, is everything we can do, I want to do that. But what if it comes out, the 4-year data comes out, or the 6-year data, or the 10-year data, and shows you actually those patients do worse because now they've got glaucoma or they have, something else that we just don't even think about at this time, and so that's a real challenge too. I mean, like the longer I've been in practice, I deal probably, I would say it's safe to say that I manage patients who have glaucoma much more frequently than patients who have diabetic macular edema. But, it's that same sort of thing is, let's say 14, 15 years ago, when that patient with ocular hypertension, maybe they've got a pachymetry of 520, really large nerves, kind of suspicious fields, not definitive glaucoma, but they're high pressures. And we start them on, prostaglandin at nighttime, and now here they are. And again, same thing. You could say that if you look at 50% of glaucoma specialists would say monitor them, 50% might say treat them, and maybe that same patient you would treat in some of those patients because they prefer treatment, and some of them wouldn't prefer treatment, and so you wouldn't. But in this case, now you see them back, and 14 years of a prostaglandin every night keeps their pressure low, but they got all this periocular and periorbital changes. And when I was first out of school, we knew it. We knew you're going to have darkening around your eyes. We knew you're going to have longer eyelashes, more pigment in your iris, maybe more inflammation. But I don't know. I mean, we had at that time, we had prostaglandins for 10 years. 2008 is when I graduated. So prostaglandins were late 90s, I think, 98. Well, now we've got them for 30 years. And really, I think it's kind of staggering. You see the effects. So anyway, my point is just it's very interesting about all of those ins and outs. And I think that's what makes practicing fun. It's what makes being a patient probably pretty challenging because they're putting their trust in our hands. And that probably does lead to some of the apprehension when we are ready to send them for other things.
No, I agree. And I think that, being humble enough to admit that we just don't know the long-term effects, right? And I tell patients, when I'm going to treat them, that there are risks to those treatments, right? And the biggest risk is you could be blind, right? You could wake up with an infection that we may not be able to treat and control. And that portion of it is something that we have to play off on why we're trying to prevent that, right? And if I look back over my career, so when I was a third-year medical student, I was rotating in a VA hospital, and I was in my psychiatry rotation, and I rounded on a gentleman that was there having hallucinations, which now I probably look back on, we were probably Charles Bonnet syndrome that he was really suffering from, because he had bilateral vitreous hemorrhages. And so here's this vet who is sitting in a chair for months on end waiting for his hemorrhages to clear, right? Because at the time with vitrectomy, the idea was, well, you had to have a non-clearing vitreous hemorrhage, right? And you had to wait. And that meant that you have people that were stone cold blind, right? Not able to sort of care for themselves, having visual hallucinations. And we don't see as many of those patients near the frequency. Unfortunately, they do sort of fall through the cracks, and we do see patients who come in with terrible, horrible tractional detachments and vitreous hemorrhages, but we don't see that level of retinopathy anymore, right? So now we're looking at more ways, how can we improve, how can we maintain and keep what we have, rather than playing a huge game of catch up that you're never going to get back to where they were as functional as they were before things fell apart. So again, there are long-term risks, but I think as our treatment modalities evolve, we're going to be doing a much better job with less treatment burden, and that lowers the bar for treatment, right? I mean, if I can treat somebody 3 times a year or twice a year,
way better,
or do something surgically that will last for a decade or so, right? I mean, that's a different than sort of threshold than I have to see them monthly, and they have to come in for injections or that run risk, right? And for the patients who are using eye drops, right, hopefully we're coming up with better ways, or knowing when to intervene and knowing where that's going to happen, because our patients live a long time, right? And you're right, it's a challenge, but is the fun part about seeing your patients over years and decades, right?
Yeah. Yeah, absolutely right. And helping them with that, helping them make informed decisions that benefit them long term and short term. So, okay, I'm going to be respectful of your time. I want to ask you, because I would be remiss if I didn't have at least some conversation. Maybe this isn't your most exciting. So I've got two questions that I sort of want to ask, but maybe I'll hold on to one of them. What is I'll hold on to one of them. What is your favorite, or like the thing that excites you the most about what you see coming down the pipeline in terms of treatment for patients who are living with diabetes or patients who are living with chronic retinal diseases? What excites you more than anything?
Yeah, I think that, if we get, on that concept of patients are living healthier lives with diabetes, what excites me most is, what our colleagues, are doing, in primary care endocrinology, how they're managing and treating those patients. Patients are living better, healthier lives with newer classes of medications and CGMs and the ability to sort of stave off severe visual loss and blindness, right? So, I would love for, retinopathy to sort of disappear, because patients are doing better with their diabetes, right? That would be an amazing aspect of what I'm excited about. As far as, within the realm of what I'm doing on a day-to-day basis, it's going to be hitting on, some of these clinical trials that, are sort of underway with, gene therapy and being able to sort of put something in the RP cells or under the retina or somewhere within the eye itself to get the eye to produce anti-VEGF agents or something else that will, help them sort of not develop severe visual loss and disease. I think that a one and done idea, right? We're going to treat somebody and or at least, treat them less is going to be hugely impactful. Now, honestly, I probably won't be around, until that happens, but, patients are going to benefit from better treatments, right? And so it's really exciting. I remember when, I went into retina, it was, all we did have was focal laser for, neovascular macular degeneration, right? And so here you had somebody who had a net and you were going to laser it, and they were going to be worse for 3 to 5 years, right? Over natural history. They left the office. And talk about an informed consent, right? Of having a conversation that you're going to make somebody worse, but long term they're going to be better. And patients just really, really have benefited from what we're doing. And I hope that the next step is that significant, right?
I would agree. I think, probably even so. Patients certainly have benefited. I would say the mental health of retinal surgeons have probably benefited quite a bit too. So Dr. Blake Cooper, thanks for being on. Tell the audience where they can find you, online, physically. Tell us about where we can get a hold of you.
Yeah, so I am in Kansas City. I'm with Retina Associates, and if you sort of look up our website, you could find my practice. I'm easy to sort of get a hold of, sort of through that avenue. But I've been in Kansas City for 20 years and plan to stay here and care for patients who live with diabetes. So
awesome.
I appreciate the time, Chris. Thank you.
Awesome. I appreciate it. I hope to be able to I might reach out to you to have you on again. This has been a great conversation. I hope you're open to it. So thanks so much for being on. Appreciate it.